So thank you very much for that kind introduction. And I want to again thank the organizers to having gone ahead. And I want to mirror what Dr. Casteras said a moment ago about congratulating them for going ahead with this meeting despite all the adversity. So I'm very happy to be here and sharing whatever knowledge I can share with all of you who are present here. And I appreciate your presence. So I'm going to talk, so Dr. Abbas has already talked to you about primary prophylaxis. So I'm going to talk about the bleeding episode and how to prevent a recurrent episode of hemorrhage. So again, in the past, we used to be always obsessed with just varices and variceal hemorrhage and not being aware that of the other complications. So as I said, as we have said before, the compensated cirrhotic patient can be divided into those with mild and those with clinically significant portal hypertension. Then and even these patients are then divided in patients without or with varices. And these are the ones that Dr. Abbas has talked about, how to prevent decompensation in the form of variceal hemorrhage. But variceal hemorrhage is not the only decompensating event. In fact, it's not even the most common decompensating event. The most common decompensating event is actually ascites and encephalopathy. So when we think of a patient with variceal hemorrhage, we have to think of whether the patient has other decompensating events. And the same, in the first decompensated stage, the patient not only has bled once, but now he has a recurrent variceal hemorrhage. But again, this has to be taken in the context of other further decompensating events like refractory ascites, hyponatremia, hepatorenal syndrome, recurrent encephalopathy, and jaundice. So these are all the further decompensated. So always when you think of patient with or without variceal, with variceal hemorrhage, think about whether the other complications are present, because this is going to clearly impinge on the survival of the patients. So we talked about this in the last talk. We know how increased resistance is the beginning of the pathophysiology of portal hypertension. Then you start with mild portal hypertension. You have this vasodilatation, increased flow. You get to clinically significant portal hypertension. And once you reach this, varices form. And once this flow increases through the varices, they will grow and they will rupture, giving place to variceal hemorrhage. So let's place all the therapies that we have in this setting. In the acute variceal hemorrhage setting, what we want is IV, intravenous vasoconstrictors, terlipressin, somatostatin, or oxybutynin that are going to constrict this splanchnic circulation so that there's less flow and therefore less pressure. Then, of course, once the patient has stopped bleeding, we have non-selective beta blockers, like Dr. Abbas just talked to you, propranolol and nadolol, and they act by causing a decrease in cardiac output, but more importantly, they act again by causing splanchnic vasoconstriction. This is the level at which these beta blockers act. Then, of course, we talked about carvedilol. Carvedilol is a very specific type of beta blocker that has these two same actions. It decreases cardiac output and it causes splanchnic vasoconstriction, but it also has an alpha-1 adrenergic blocking effect that causes vasodilation inside the liver, or at least that's what we think it does. So it has a dual effect, both in resistance and in flow. Then finally, we have TIPS. TIPS, by connecting the hypertensive portal system with a normotensive system, is going to relieve the portal pressure entirely. Then we have statins, what we'll talk about, and Dr. Jordi Garcia Sancho this morning talked very nicely about statins, how they act at this level by causing vasodilation inside the liver by improving nitric oxide bioavailability. And then, of course, ligation is a local therapy. You ligate the varices, but you have nothing to do with any of the pathogenic mechanisms. This is something important for you to realize, that ligation is a local therapy. It may prevent variceal hemorrhage, but it's not going to prevent ascites or any of the other complications of cirrhosis. Now, of course, glue is also for fundal varices. Again, it's a local therapy. BRTO, like Dr. Maruyama talked to us before, is going to be good for fundal varices, and I will not go into this. So in patients with acute variceal hemorrhage, so my talk is about variceal hemorrhage. So this is a patient that's bleeding. Our main objective is to stop the bleed and to prevent recurrent variceal hemorrhage. And we'll talk about that in the next talk. And by doing this, we expect to decrease mortality. And in fact, this is about about the only complication of portal hypertension that all these years of research have resulted in a decrease in mortality. The only, ascites, we have not really achieved any decrease in mortality. So with all these investigations, we have achieved a decrease in mortality. And in this particular study, this decrease in mortality was due to having used prophylactic antibiotics, having used the intravenous vasopressors like I talked to you about, and with using ligation instead of sclerotherapy to stop the episode of acute bleeding. So these are following our guidelines for the ASLD. When you suspect that someone has variceal hemorrhage, and you suspect it in any patient that you know has cirrhosis, that is now vomiting blood or has melena, or in patient that looks like the patient may have cirrhosis or has risk factors for cirrhosis, that comes bleeding to the emergency room. So once you suspect this from happening, you're going to do cautious packed red blood cell transfusion, meaning you do not want to over-transfuse, because you over-transfuse, you replenish the volume, and then the vessel gets bigger and they're going to bleed. So you want to start transfusing only after the hemoglobin has reached 7, not more than that. And then you keep that hemoglobin around 8. Then you do short-term antibiotic prophylaxis, and the recommended antibiotic is ceftriaxone, because this has also been shown to decrease rebleeding. And then you use a safe vasoactive drug like somatostatin, octreotide, and terlipressin. I don't know, in the US, we only have octreotide, so that is the only vasoconstrictive substance that we use. Now, we're talking about beyond the guidelines. So in the guidelines, we never say anything. So in general, if the patient comes in bleeding, clearly there's a possibility like up to 20% that the patient may be bleeding from ulcers, from a peptic ulcer. So you have to start a proton pump inhibitor IV, right? So the issue is then, guidelines say that within 12 hours you have to do an endoscopy to show if the patient is bleeding from esophageal varices. And the data that shows that patients are bleeding from varices, because one, you see blood spurting out of the varix, number one. Number two, if you see a white nipple sign or a clot on top of the varix. And number three, and that's the most important, is if you see varices and non-bleeding varices and no other lesion that would explain the bleed, that defines variceal hemorrhage. So if you go in, varices are very sneaky. They bleed and then nothing is there. So you have to go in there. If you see nothing else, that patient bled from varices, and you have to do the ligation and everything else. But I would say, this is beyond the guidelines, that once you confirm that this is varices, PPIs do nothing for variceal hemorrhage, so one should probably stop the PPI either then or during that admission for sure, because PPIs, in a patient with cirrhosis and minimal hepatic encephalopathy, for example, and this is a study, a very recent study, the development of overt hepatic encephalopathy and death, this is overt hepatic encephalopathy, on the right you see the survival, was high, death was higher in PPI users than in non-users. So actually PPIs are very deleterious for the patient with cirrhosis. Look at this, more encephalopathy in patients with PPI, 64% in PPI users versus 25 in non-users, and look at the survival. The survival is also lower. So, and this is another study from Dr. Bajaj that looks at the PPI use in hospitalized patients with cirrhosis associated with higher 30-day readmission rates. So I would claim that this is beyond the guidelines, that once you prove that the bleeding is from varices, you can stop the PPI. Now, you do the ligation, you confirm that these are esophageal varices, you have to ligate those varices, and this is standard therapy. And normally, one would say we continue the vasoactive drug for 2 to 5 days, and then if the patient doesn't bleed, you stop the vasoactive drug, and at the same time you're tapering them off the octreotide, for example, we start the non-selective beta blocker. So we're already thinking of doing secondary prophylaxis. Now, there's a group of patients that will rebleed, or patients who the bleeding is not controlled with the first ligation. And in these patients, we think of doing what is called a rescue TIPS. So the patients have failed the primary treatment with all these measures and ligation. Despite this, these patients bleed. So then you put a TIPS in that's a rescue TIPS. But who are the patients that are most likely to fail this therapy, these are child C patients for sure. And many studies have shown this prominently. These studies have shown that child C patients are the most likely to fail standard therapy. So this is the basis of thinking, what if before the patient fails, right here, right after we finish that first ligation, we put a TIPS in preemptively? Because if a child C patient gets a TIPS because they bled a second time, they're going to be at a high risk of dying. These patients may not bleed, but they die a lot. So the history of preemptive TIPS, or what used to be called early TIPS, is that you're going to preempt this failure by putting a TIPS in before the patient fails. So this was a study by Garcia et al. This is a multi-center European randomized controlled trial in which they used preemptive TIPS in what they call high-risk patients. And you can see here how, they enrolled 63 patients, half of them were child C, but not too sick patients, so only 10 to 13 points. They excluded child C of 14 and 15 points, and they looked at child B with active bleeding at endoscopy. They placed the TIPS within 72 hours, and in a median follow-up of 6 months, you can see here that the failure only occurred in 1 preemptive TIPS versus 14, but importantly, look at the mortality rate. Only 12% in the preemptive TIPS versus 39%, which was significant, with a 1-year absolute risk reduction of 25%. So remember this 25% risk reduction, 25% less risk of dying in these very sick patients. The question has always been, child C, we know that they fail, but child B with active bleeding has not been that clearly confirmed. So this has been always the question, what to do with the child B patients. And active bleeding means that when you went in with the endoscope, the varix was spurting blood, all right, which is not very common. So trying to solve this question, Mendes and collaborators looked at an observational European study, and they divided them in child C 10 to 13 points versus child B with active hemorrhage. And you can see here that the only group where preemptive TIPS was good in decreasing mortality was the child C group. Look at the child B with active hemorrhage, there was exactly the same non-significant difference in mortality with standard therapy versus preemptive TIPS. So it seems that it's these patients that benefit the most from preemptive TIPS. But then there was a huge or observational study from the Chinese, which unfortunately are not with us to discuss these results, but they have a huge study of preemptive TIPS, but they included all of the patients, child A, child B without active bleeding, child B with active bleeding, and child C 10 to 13 points. And they found that in child A or B without active bleeding, there were no differences whether you gave them medical concern, the standard therapy versus early TIPS. Whereas in child B with active bleeding, and in child C patients, that's when you saw the difference. But again, they did not have enough power, even though they had a huge number of patients, they did not have enough power to determine the differences between child B with active bleeding and child C. When they looked at the MELD, the best survival was those in the high MELD, a MELD of greater than 19, which is sort of counterintuitive because my interventional radiologists always are very scared of putting a TIPS in a patient with a MELD of more than 19. Then they did, and this is just published last year, the end of last year, this is a randomized controlled trial. Again, they had 84 patients randomized to preemptive TIPS versus 45 patients randomized to standard therapy. This is a larger study than the study by Garcia Pagan. It's a randomized controlled trial. It's a very important trial. They found that the patients that were randomized to preemptive TIPS, they had a better transplant-free survival, they had a lower rate of rebleeding, they had less new or worsening ascites, and no differences in encephalopathy. Very impressive. This study included mostly patients with hepatitis B cirrhosis, most of whom had been treated. And remember that 25% reduction in the Garcia Pagan study. In this study, the 1-year relative risk reduction was only 13%, so it was a lower difference. And the reason for this is because most of the patients were child B. Look, 57% did not even have active hemorrhage, and 21% had active hemorrhage, but only 22% were child C. This indicates that in a way, this lower risk reduction was because the patients that they included in the study were less sick patients. So we're still not clear as to what to do with the child B patients. So what we do now, however, is that once we do the endoscopy or we do the ligation, we stratify the patient. This is individualized medical care. We say this patient is not high risk, is a child AB, versus high-risk patients. And for now, I can tell you that the high-risk patients are clearly, those are our child C, 10 to 13 points. These patients are going to go to standard therapy like I described. You continue the vasoactive drug, you discontinue the drug and start the beta blockers after 5 days. If they rebleed, they go for rescue tips. These patients, right after you do the ligation and before they fail, within 24 to 48 hours, you put in a TIPS, what we call preemptive TIPS, and must be, this is the last Baveno recommendation that says must be considered in selected patients. With the extra data that we now have, I am sure that the next Baveno, which is now going to take place in October, hopefully, we will say must be done, I think, in patients, and probably the group, what are the selected patients? I think that clearly the signal is for child C, 10 to 13 points, and it's still questionable about child B plus minus active bleeding, and we have to wait for meta-analysis of all the data to figure out who are the child B patients that will actually benefit from preemptive tests. I think that the child Bs without active bleeding are not candidates for preemptive tips. Anyhow, so this is what we have for new in terms of treatment of variceal hemorrhage. But almost immediately, and even before the patient leaves, if you do nothing to these patients that have bled, 60% are going to bleed again. And this is the untreated groups of 19 trials. 60% rebleed within 1 year. This is much more scary than what Dr. Abbas showed you, which was preventing the first bleed rate, which is only like 12-15%. So here, anxiety levels are very high, because if you do not do something, the patients will bleed again. So then the best treatment has been the combination of ligation and drugs, not one or the other, like Dr. Abbas showed you, but the two therapies together. So now it becomes much more important whether we're going to use beta blockers or not. And this is, and in the past, when we did all these studies, we used to combine. We forgot about all the other complications, and we combined patients that had ascites, for example, a patient who did not have ascites. We combined all compensated and decompensated patients. But knowing what we know now, what we decided to do is look at all these trials of ligation and drugs and stratify them on whether they were child A, which are compensated patients, they had no ascites, and child B and C. So in the blue panels, I'm showing you so we asked the authors for their individual data of all these trials. And you can see here that these are the blue panels is beta blocker alone versus combination therapy, ligation, and beta blockers. What we're examining here is the advantage of adding ligation to the beta blockers. And you can see here that overall there's no differences when we looked at the stratified. And it seems like child A are the ones that benefit the most from combination therapy, although this is sort of counterintuitive, but that's okay. In the death, there were really no differences. So one, in theory, could use either combination therapy or beta blockers alone. The important ones are the lower panel. The lower red panel is when all the trials that combine ligation alone versus combination therapy. So what we're analyzing in these studies is the effect of adding the beta blocker to the ligation. And you can see here that here the differences are immense. Overall, there's much more benefit of combination therapy than ligation alone. But more importantly, in child B and C, that's where we see the difference. Less rebleeding and less mortality. This is pretty amazing. We're showing differences in mortality in child B, and because we had the individual data, we could actually do a Kaplan-Meier curve, and this is what it looks like in child B and C patients. If they are with combination therapy, survival is significantly better than if they're left on ligation alone. So in these patients that are decompensated patients, child B and C, is where the use of beta blockers is particularly important, and you cannot leave them on ligation alone because the mortality is going to be higher. So bottom line, non-selective beta blockers are the key component of combination therapy, particularly in these very sick patients. So we have to use beta blockers. So I'm summarizing the studies that showed, these are the first two studies, the study by Cerste and Mandorfer, that showed that beta blockers were deleterious in patients with refractory ascites or with SBP, with the mortalities that were 2.6 times higher mortality, 1.5 times higher mortality in those on beta blockers compared to those not on beta blockers. Since then, there have been a lot of studies showing the opposite, but I'm going to show you the ones that looked at dose and that looked at mean arterial pressure. And this is a study in the UK of patients with ascites on the transplant list. This is a study in patients with acute on chronic liver failure. And then we have, and these two studies actually showed a benefit of beta blockers, a lower mortality. Here we're talking a 65% lower mortality, and this is a 40% lower mortality in very sick patients. And then there's another bunch of studies that showed, including one that we did in our hospital, that showed that there was no differences in mortality between beta blockers and no beta blockers. So, there's a meta-analysis that shows that there's absolutely no differences, but it combines all kinds of patients. That's why I do not like meta-analysis, because you just get you combine a lot of patients. But if you look at these studies, the French and the Viennese study, look at them. The beta blocker group, in terms of mean arterial pressure, had a lower pressure, 83/77, and whereas this one, so these one here had the better mortality, had a lower, and I'm going to show you this now. Look at the blood pressure, and all the other studies did not show a great difference in blood pressure. And the beta blocker dose was higher. Dr. Castelar will tell us here they use usually higher doses of propranolol than we use. And there's a study by Mukherjee, for example, only used 40, and that showed the benefit of beta blockers. So it seems to be mean arterial pressure related, and this is probably a result of the dose used. So this is another study that is not in the table that I showed below you. That was a study that is a propensity match study in patients with refractory ascites, and these are the blue is the propranolol patient, better survival compared to patients not on propranolol. But when they divided these patients by dose, look at this. This curve here, which is horrible, was the more than 160 milligrams a day. So it seemed to have to do with the dose of the beta blocker that you use, and this has to do obviously with the mean arterial pressure. And this is the study that Dr. Abbas already showed you. This is the group from Michael Manz in Germany. They looked at patients with ascites after their first LVP, meaning these were already patients that were started to be refractory to diuretics. When you look at overall, the green line is the non-selective beta blockers, better survival than no non-selective beta blockers, but it was entirely dependent on the mean arterial pressure. Look at this. If the pressure was less than 65, no difference. It was significant when the mean arterial pressure was more than 65. And the same for patients with SBP. The main benefit, if you see these two panels here, was if the patient had a MAP more than 65. So for the beta blocker to be effective, you have to maintain that mean arterial pressure that is high, not a low pressure. And the same for patients with acute on chronic liver failure. The differences were significant only in those who had a mean arterial pressure more than 65. So non-selective beta blockers are beneficial in patients with ascites, refractory ascites, SBP, and ACLF, as long as the mean arterial pressure is more than 65. So this is the AASLD guidance. We say that refractory ascites and SBP are not absolute contraindications for treatment with non-selective beta blockers. And in patients with refractory ascites or SBP and systolic pressure less than 90 or a MAP less than 65 or acute kidney injury, the dose of non-selective beta blockers should be decreased or the drug temporarily held. Once whatever caused the patient to be hypotensive resolves, you can reintroduce this if the mean arterial pressure resolves. Now, we're going to go beyond the guidelines. And there's evidence, like I said, that statins may decrease portal pressure by another mechanism. It acts on resistance. So in this study by Dr. Abrales et al., which is a multi-center Spanish study, you can see here that patients these are patients that bled from varices. They were all on beta blockers and ligation, and then they were randomized to simvastatin versus placebo. And the primary endpoint was a joint primary endpoint, but you can see here that there were no differences in terms of rebleeding, but in mortality, simvastatin was significantly lower mortality compared to placebo. So this is a benefit in survival by the use of statins. And the causes of death were mostly rebleeding or infections. So this is a single trial. They did not meet the primary endpoint because the primary endpoint was a combined endpoint. However, there's clearly a signal that statins are going to be useful in the treatment of portal hypertension. The problem was that was not hepatotoxicity. The problem was that they developed symptomatic rhabdomyolysis, and it occurred in 3%. That's only 2 patients, but the percentage is much higher than in the general population. And both patients had a bilirubin more than 5. So it seems that the sicker the patient, the more they can get this complication. And in fact, this was recently, actually, this has already been published. This is the Liver Hope trial, which is a multi-center trial of child BC patients that are going to be randomized to placebo versus simvastatin 20 plus rifaximin versus simvastatin 40 plus rifaximin. And so they were required to look at a safety study before actually starting the trial. And so these are the results of the safety trial. And you can see that the creatinine kinase was high had these peaks in the 40 milligram dose, and the AST, which we think is coming from the muscle, was also higher in the 40 milligram dose, but not in the 20 milligram dose. With the 20 milligrams, there was no evidence of rhabdomyolysis. What is a little bit concerning is that one of these patients that had the AST that was high also had a high INR, which makes you suspect that there was some kind of degree of liver insufficiency and maybe hepatotoxicity. But and in a paper that we're going to present in May in DDW, in the NACL cohort of hospitalized patients with advanced cirrhosis, statin use at admission was associated with higher inpatient mortality. But these are very sick patients. So the bottom line is perhaps that simvastatin should be used very cautiously and never at a dose more than or equal to 50 in decompensated patients. So more to come about statins. So this is my last slide. Mortality is high still, particularly in child C patients, in patients with acute variceal hemorrhage. The general management strategy is based on careful transfusions, antibiotics, and intravenous vasoconstrictors. The specific management, you have to ligate the varices that are bleeding. Early preemptive tips should be considered in child C 10 to 13 points. And the prevention of rebleeding is based on non-selective beta blocker, and this is key, and ligation. I would even surmise that if for some reason the patient is not a candidate for beta blockers and you're going to leave them on ligation alone, it may be easier to consider TIPS placement, especially if the patient has a side or you have any other excuse to put a TIPS in. Thank you so much for your attention.